Hello, in this video we are going to talk about long COVID-19 in children, clinical overview and public health implications. So, long COVID, also known as post-acute sequelae of SARS-CoV-2 infection, refers to the persistence or emergence of symptoms beyond the acute phase of COVID-19. Although children typically experience mild acute infections compared to adults, emergent data suggest that a significant proportion may develop long-term symptoms impacting their physical, cognitive, and psychological health. So we are going to talk about long COVID in pediatric populations, focusing on prevalence, symptoms, pathophysiology, diagnostic approaches, and management strategies. Definition and diagnostic criteria. Long COVID in children lacks a universally accepted definition. However, most studies adopt definitions similar to those used in adults, such as definition of WHO, World Health Organization. According to this definition, symptoms persisting for more than 2 months and occurring within 3 months from the onset of COVID-19, not explained by alternative diagnosis. Definition from UK NICE, persistent symptoms lasting more than 4 weeks post-infection. In pediatric contexts, adjustments are often required due to differences in symptom reporting, developmental considerations, and baseline health variability. General prevalence. Systematic reviews estimate that from 16 to 30% of children may experience at least one symptom of long COVID following infection. A meta-analysis of over 80,000 children showed a pooled prevalence of approximately 25% for post-COVID symptoms. Variant-specific variations exist. Delta variant, higher prevalence, approximately 30%, and Omicron variant, lower prevalence, approximately from 16 to 18%. Age, gender, and distribution. Long COVID is more frequently reported in older children and adolescents from 12 to 17 years and females. These demographic groups also report higher levels of fatigue, mood disturbances, and cognitive symptoms. Clinical manifestations. Long COVID in children presents as a multisystemic condition with a range of non-specific and organ-specific symptoms. Common symptoms with estimated prevalence: fatigue approximately from 9 to 30%, mood disorders from approximately 10 to 17%, sleep disturbances from 8 to 12%, headaches from 8 to 10%, dyspnea or respiratory complaints from 7 to 9%, cognitive difficulties from 6 to 8%, myalgia and arthralgia from 5 to 7%, anosmia aghasia from 5 to 6%, exercise intolerance from 5 to 6%, and gastrointestinal issues from 3 to 5%. So, age-specific differences. Children aged from 6 to 11 years tend to report headache, difficulty sleeping, abdominal pain. Adolescents from 12 to 17 years more frequently experience fatigue, musculoskeletal pain, memory or focus problems. So, about pathophysiology. Proposed mechanisms. While the pathophysiology remains under investigation, several mechanisms are hypertaste, immune dysregulation, persistent inflammation, cytokine activation, endothelial and microvascular injury, viral persistence in tissues, for example in gut, olfactory bulb, autonomic nervous system dysfunction, and psychological stress related to the pandemic environment. Risk factors. Evidence points to the following risk factors in pediatric long COVID: older age within the pediatric range, female sex, severe or symptomatic acute infection, pre-existing conditions like asthma, allergies, and anxiety, etc., socioeconomic stressors, for example, limited healthcare access. Diagnostic approach. There are currently no standardized diagnostic tests for long COVID in children. Diagnosis is primarily clinical and involves detailed medical and infection history, physical examination, symptom checklists, functional assessments, and baseline investigation to exclude other causes. Diagnostic challenges: lack of validated pediatric tools, overlap with post-viral syndromes, psychiatric conditions and functional disorders, reliance on parent or caregiver observations in younger children. Management strategies, general principles. Management is supportive, individualized, and often multidisciplinary. There is no universally effective pharmacologic treatment for pediatric long COVID as of 2025. Non-pharmacologic interventions, for example, physical symptoms, possible intervention, gradual activity pacing, light exercise, physiotherapy. Cognitive dysfunction, possible intervention, cognitive behavioral therapy, school accommodations, sleep disturbances, possible interventions, sleep hygiene, behavioral modifications, psychological support, intervention counseling, play or art therapy, family education, nutrition, possible intervention, balanced diet, consider supplements if deficiencies are identified. Pharmacologic considerations. Symptomatic treatment may include analgesics for headaches or muscle pain, antihistamine for fatigue, anti-inflammatory agents. Experimental therapies also possible, but are being studied but not routinely recommended in children. Course of illness. Most children recover within approximately from 3 to 6 months post-infection. A minority may experience symptoms persisting beyond 12 months, especially in older adolescents. Symptom resolution may be fluctuating rather than linear, often with relapses following physical or mental exertion. Public health and policy implications. Surveillance and research. Pediatric long COVID remains underreported due to diagnostic uncertainties. National database and research programs are critical to improving understanding. Educational support. Schools may need to implement accommodations, reduced workloads, modified attendance in school health monitoring. Healthcare system challenges. Lack of pediatric long COVID clinics in many regions. Need for coordinated care between pediatrics, neurology, pulmonology, psychology, and education sectors. To sum up, long COVID in children is a real and impactful condition characterized by a wide spectrum of lingering symptoms following SARS-CoV-2 infection. While the majority of children recover within a few months, a significant minority experience prolonged physical and psychological symptoms. The current approach to diagnosis and treatment is largely supportive and multidisciplinary, emphasizing the need for continued research, standardized diagnostic tools, and better clinical guidance tailored to the pediatric population. I hope this video will be useful. Thank you for your attention.